We're privileged to have amazing panelists today, starting with Suzanne Gordon, an award-winning journalist and author. She has written for the New York Times, the LA Times, the Washington Post, among others, and is the author or co-author of 11 books, including Wounds of War, How the VA Delivers Health, Healing, and Hope to the Nation's Veterans. She is the Senior Policy Fellow at the Veterans Healthcare Policy Institute. Suzanne will be followed by Dr. Jim Martin, an emergency medicine physician at the James A. Lovell Federal Healthcare Center in North Chicago, which is run jointly by the Navy and the Department of Veterans Affairs. He blogs about the shift towards VA privatization and how it is affecting patients, doctors, and the VA. Jim will be followed by Lakiesha Lloyd, a disabled Army veteran who served in the U.S. Army from 2001 to 2010. She is a climate justice organizer and lead West Virginia organizer for Common Defense. Lakiesha will be followed by Bruce Carruthers, a service-connected Army Vietnam vet who worked for the Department of Veterans Affairs healthcare system for 30 years. He is active in Vets for Peace, Save Our VA National Project, and is the current president of the Western North Carolina Veterans for Peace local chapter. So Suzanne, go ahead.
Thank you. Thank you so much. I'm probably going to take a few more minutes than anybody else, just because I'm going to give an overview of the VA and the VA healthcare system. And so I'm going to just jump into it. And I just want to give a shout out to National Single Payer for doing this, and to my really close colleagues, Lakiesha, Jim, and Bruce, who work in 3 organizations that are really fighting VA privatization, which I'm going to get into in a minute. So I've been working on writing and researching healthcare for something like, I don't know, close to 35 years, and have been very active in the movement to get our country a national healthcare system. And I began writing about VA healthcare about 15 years ago, and really was struck by how, if you have your checklist of everything that we want from a healthcare system, we want safe care, we want evidence-based care, we want equitable care, we want patient, not profit-centered care, we want timely care, we want coordinated care, we want cost-effective care. Now we want trauma-informed care, and we want care that considers healthcare that isn't just disease-focused, but both an individual-focused, but population-based and informed by social determinants of health. One could probably add many more boxes to the checklist, but if that is part of your checklist, and you look at American healthcare, there is only one system in the US where you check every single one of those boxes. And that is the Veterans Health Administration, which is run by the Department of Veterans Affairs, the VA, which is the 2nd largest agency in the federal government, and runs the Veterans Benefits Administration, which is the largest benefit enterprise in the US, and also the Veterans Health Administration, which is the largest publicly funded and only fully it's the largest healthcare system in the country, and it's the only publicly funded, fully integrated healthcare system. And so, when we look at Medicare for all, and we look at VA, the difference is that the VA isn't just a payer, it's a provider of care. And that makes it much easier to innovate in the VA system, and it also makes it easier to solve some of the problems many of the problems that we have in American healthcare, which aren't just about payment, but also about like what kind of care we get. And so when I started writing about the VA about 15 years ago, I knew a lot about private sector care, and I really didn't know much about the VA. And I think that's true for many of us. I think that I do. I go around the country, I talk to everybody from Rotary clubs to PNHP meetings to social justice meetings and patient justice meetings. And now I start out with a kind of a little quiz. And it's interesting because I often have one of my books with me, either my book, Wounds of War, How the VA Delivers Health, Healing, and Hope to the Nation's Veterans, or Our Veterans, which is my latest book, which I co-authored with my husband and somebody from VHPI, Jasper Craven. And I always start with a little quiz, and I say, I'm going to give one of my books free to anybody who can answer one of these questions. I mean, I've learned that all of these questions, and a lot of times, even in a group like a PNHP group, I never give away a book because people can't answer the questions. And the questions are, and think about these questions, did you know that one of the VA's mission is to deliver clinical care to veterans? Pretty much everybody knows that, but very few people know that the models of clinical care that the VA has developed are ones that could teach a great deal to the American healthcare system, and the VA does teach them to the American healthcare system. I mean, the integration of mental health and primary care is done, as far as I know, only in the VA. Geriatric primary care, appropriate end-of-life care, giving nurses a voice, team-based care, care coordination, which goes way beyond, and Jim will explain this a bit, way beyond just the sharing of the same medical record and people entering notes in a chart. In the VA, providers and support staff actually talk in teams about talk to one another and plan about care for complex patients. The VA is mission driven, not profit driven. And that is helped by the fact that everybody's on salary who works in the VA. It's not fee for service. There's no incentive to deliver more futile treatment, expensive futile treatment, and there's no incentive to deliver less. The VA, so these models of clinical care that the VA delivers are really impressive, and one of them is emergency care, the kind of emergency care that Jim will talk about. And there was just a study in the British Medical Journal that showed that if veterans who they analyzed 500,000 ambulance rides, over 500,000 ambulance rides, people were sort of quasi randomly sent to either private sector hospitals because the vets had Medicare, or VA hospitals. And the veterans who went to VA hospitals, the veterans who went to private sector hospitals were twice as likely to die in the first 28 days, and the care cost 21% more. Why was care better at the VA? Not just because they share the same electronic medical record, but because there's an amazing care coordination in the VA that extends to someone who goes to an emergency room. And I remember reading that study and two other papers by the same authors about what they call the VA survival benefit. And I remember thinking, like, how come I can't have this? Like, why can't we all have this kind of care? When I see the care delivered in geriatric primary care to some of my friends who are veterans, and I'm 77, I will never, with my Cadillac insurance, plan, get anything approaching the kind of care that veterans get. The VA does better what our healthcare system, or our healthcare non-system, or our healthcare arrangement, I hate to call it a system because it's not, what our healthcare non-system doesn't do at all, which is be primary care based, offer considerations not just of fragmented episodic treatment, but real health care, team-based. And in the VA, in order to encourage people to function on teams, for example, in primary care are not led by a doctor. They're led often by the clerk or the LPN, which encourages the, lower status people who are afraid to speak up to actually talk about and help plan care. The other thing that I find really impressive about the VA is that it has geriatric care. It practically invented geriatric care, right? And I recently had a friend go to the VA who was 87 years old. And I said, I want you to go to this primary care doctor who is a friend of mine, and I had it all organized. And they called him back and they said, no, you shouldn't go to the primary care, clinic. You need to be seen by geriatric primary care, right? This was a gentleman who was being taken care of by Kaiser in Northern California, where I think they might have one geriatrician, right? We have 7,600 geriatricians in America for 30 million people over 65. The VA also has care that is population-based, but also that is informed by social determinants of health. When I was writing Wounds of War, I spent hours with a social worker in San Francisco going around looking for homeless veterans to try to get them into care at the VA. And I don't, if a homeless person goes to UCSF, right, they don't really want them. They're certainly not scouring Union Square for homeless veterans. Just as an example of this, in primary care, every primary care clinic has a social worker, a pharmacist, and a nurse practitioner, psychiatric nurse practitioner or psychologist. At UCSF in San Francisco, where the primary care clinics are now closed to any new patients and have been since February of 2022, there is one social worker for 28,000 patients. Why? Because our healthcare system doesn't want to deal with complex patients and their social needs. And the VA, is loaded with social workers. The VA is one of the only healthcare system that employs anthropologists, to look at the cultural needs of veteran patients. The VA is under attack now because it is performing abortions in states for limited reasons, in states where there are abortion bans, and the Republicans are trying to get that reversed. The VA also, I think, is the only healthcare. I mean, I would argue that the VA has the only functioning mental health system in America, but it also has trauma-informed primary care. It offers trauma-informed primary care. And really, for those of us who are interested in trauma-informed primary care, we now understand that if properly delivered, primary care can serve as a protective factor to mitigate the impact of trauma. And I would argue that the VA as a system is a protective factor for veterans. I mean, one has only to go into a VA waiting room, and it's like the completely different experience that most of us experience who aren't veterans when we go into a waiting room in our doctor's office, where, often the staff is, at best indifferent, if not outright hostile. And people never talk to each other in the waiting room. In VA waiting rooms, there's a community, people talk to each other in the canteens, they talk to each other. I once sat down in the canteen at Fort Miley in San Francisco having lunch, and a vet sat down next to me and he asked me what I was doing there. And I told him I was writing a book about VA care. I didn't ask him about his experience. And he says, oh, I have to tell you about my mental health care. And oh my God, my anger and PTSD, and you have to talk to so-and-so. The veteran was telling me that, and I was actually there to talk to that so-and-so, right? And then another vet was sitting next to us, and he said, oh my God, I have to tell you about, I just have to talk to you because I have to tell you about my experience. And he started telling me about, how his wife was saved from his anger, and he used to beat her up, and now he was in treatment. And then another vet came by and gave me, I mean, you couldn't make this up, gave me a slip of paper, a napkin with his phone number written on it saying, please, call me. And I mean, I've been writing about healthcare for 35 years. I've sat in a lot of cafeterias. That has never happened to me ever. And I think that what this shows is that the VA has created a community of care, not just for patients, but for those who deliver care. And it has really worked on doing that. And it's under attack now because privatizers can't stand community, right? The very same people who are trying to destroy Medicare for all, traditional Medicare, are the very same people who are trying to kill the VA, and they are out to get it relentlessly. This includes not just the Koch brothers funded groups like the American Enterprise Institute, Pacific Research Institute, who attack, single payer, or Medicare for all, or any proposal at all to ameliorate our broken healthcare system, but it also includes groups like United Healthcare, that is now, whose subsidiary Optum is now one of the third-party administrators of this Veterans Community Care Program, the outsourcing and privatizing program that was enacted in the VA Mission Act of 2018 with a bipartisan coalition of Democrats and Republicans. It's a bipartisan coalition of Democrats and Republicans, the same folks who want to destroy traditional Medicare, who want to destroy our only functioning public healthcare system in this country. And that is why we need to stop it. And that's why we're here today, is to really get folks informed about the VA, so that not only so that they can respond to attacks that use the VA to attack proposals for healthcare reform, but also defend the VA and stop VA privatization, so that when you are all fighting for Medicare for all, or whatever brand of healthcare for all we are fighting for, that you can also be effective advocates against the privatization of VA healthcare. And I just want to add one little note on that, and I hope we can get to this in questions. But one of the pernicious things about the VA privatization movement is that the very people who are trying to privatize the VA know that the P word is anathema to veterans who really don't want their system privatized. And so if you ever speak to congressional representatives about VA privatization and speak against it, it's very important not just to say privatization, but the outsourcing of care to the private sector, because the very same people who want to privatize the VA will say, oh, no, we're not for privatizing the VA, because they define privatization as shutting down the VA system completely overnight and selling off everything to the private sector. And what they are doing is the sort of salami or stealth privatization where, you just kill it piece by piece. So I really want to thank you, and I know we'll have time for questions, and turn it over to Jim Martin. Jim really, I think, has a unique perspective because he worked for a long time in the private sector and as an emergency medicine physician, and now works at the VA. And I'm very excited that he is joining us. Jim and I have worked together. Jim is part of the American Federation of Government Employees National VA Council, and we are working together on a report that will be released about the impact of privatization on VA staff. It's going to be released next week, and I can send it out to all of you when it is. Right now it's embargoed, but Jim.
Okay, well, good evening, everybody. I'm Jim Martin. I'm an emergency physician. I started my practice in Chicago in January of 1978. And I'm married to a nurse, and she was carrying health insurance for the family. I have 3 children. And in 2006, she was going to retire and take care of a newly arrived grandson. And I had to go find a place to get insurance. Now, I've been in practice for 28 years, and it was not an easy thing to do. But at the time, I was going through the journals looking for opportunities, there was an advertisement from North Chicago. North Chicago VA Medical Center was merging with Great Lakes Navy Base, and it was going to be a joint facility. And they were looking for board certified physicians. So I applied. And at the moment that I sent my curriculum vitae by fax to the director, somebody that knew me was in the room and said, "Oh, you got to hire this guy. I know him. I've worked with him." So just the timing was perfect, but I got the job. So I've been with the VA since 2006, taking care of both veterans and active duty Navy recruits and the family members of the active duty Navy. So it's not a typical VA practice. I had left a teaching position at Michael Reese Hospital in Chicago, which was an affiliate of University of Illinois. And that was a rewarding career, but I wasn't anticipating what I was going to find at the VA. And finally, for the first time in my career, I was able to deliver care the way it was supposed to be delivered. My patients were being followed up. The consults were being followed. The notes were being, the electronic record was, I could see the patient, do a note, copy the primary care doctor's note or whoever he had been seeing, a specialist, cardiologist, whatever. So in the instant that I was seeing the patient, I was creating a network of contacts for the patient for his follow-up care. And medications, they would always get their medications because right there's 24-hour pharmacy. And as I wrote the prescriptions, they were ready for them before they left the hospital. So this was wonderful. So things changed recently with the Mission Act and consults to community care. And this vignette that I'm going to talk about is in the report that you're going to be receiving shortly, that Suzanne has authored, and we had a work group that put it together. But one night I was working and I had an older veteran come in with chest pain. And 2 weeks prior, he had been at another hospital, a Northwestern affiliate just up the road, and he had a cardiac procedure. He had stents put in. So I didn't have a recent EKG on him. He was having chest pain. I wasn't sure what was going on. I looked in the chart and we did have the other medical record. It was scanned into our system. So I opened the record and I started going through it. Now, this is 82 pages of information that I couldn't process on a computer screen. So I had to print out the 82 pages because I didn't know where the essence of what I was looking for was going to be in those 82 pages. I printed it out, flipped quickly through the chart, got the information I needed. But what I really needed was a copy of the EKG and possibly a chest x-ray. And I'm spoiled now. I work for the VA and this information is at my fingertips. If I have a patient, I can go to his old EKGs and compare his new actual EKG. I can look at his old x-rays. I can see what's going on. So it was not optimal, but it worked for him anyway. We got the information we needed. But what's happening now with the community care consults, if we don't have the ability to get a patient timely seen by a specialist, now not mental health, we run a tight ship, but we're short a cardiologist and we're sending a lot of our cardiology consults out into the private sector, and then we lose them for a period of time. And when they come back to us, you know, it's a scanned record into our record, a PDF file, and it's not easily accessible. Again, you have to print and look through the document to see what you got. So it's a fragmentation of the seamless care that we were providing at the VA. I'm lucky that I was able to get to the VA at this time of life because after working for 28 years in a dysfunctional system, I finally get to a system the way it's supposed to be, and it's very rewarding. I've also been a member of the Physicians for a National Health Program since since Bush 2 was president. And, you know, I'm dedicated to the mission of getting a national health care plan. And we got to have it. I think the other issue that we have to address seriously is a national electronic healthcare record, which is totally interoperable between systems. I mean, the hospital cartels seem to all go for different systems which don't communicate easily with. That's an issue that I think is, if we're looking for a national health plan, a good place to argue is for a national health record, an electronic health record. Suzanne, can you, is there anything else you want me to cover? You're on mute.
I think that's right. I mean, I think that it was impressive to me when I interviewed Jim about, you know, his experiences just about what it means to be able to take care of people who already have primary care, and who can get follow-up care, and how, you know, I think it's very interesting to talk to someone who's had experiences both in the private sector and, you know, in the VA. So I thank you very much, Jim. And Lakeisha, I think it'd be great if you would talk about your experiences.
Yes, thank you, Suzanne, and thank you everyone for joining tonight. So my name is Lakiesha Lloyd. I am a climate justice organizer with Common Defense. We are the largest veterans-led grassroots organization in the country. And I have the honor of serving and doing my due diligence here in the state of West Virginia. So I am currently, the VA Medical Center is my primary care. I have been seeing the VA since I got out of active duty service in 2010. I was in the United States Army from 2001 to 2010. And, you know, with service, we incur injuries, and we, you know, incur, you know, mental health issues and disabilities with that. I myself am a service-connected disabled veteran, and all of my services through the VA. From the mental health care that I receive there, I do have PTSD. I do not have a problem with talking about that. It's part of who I am, and it came from my service and my time in service. But thankfully, I have the VA. I have had some of the best care in my life through the VA healthcare system. I mean, they take care of everything for me. Of course, you know, I'm super grateful for our women's care center that we have in the VA and that we find in our VA medical centers. I mean, I have, you know, dealt with a lot of health issues in my life, and being able to have that centralized care, being able to have practitioners and, you know, and nurses in that space who understand what it's like for women veterans and the health issues that we have, and just what it actually means to be a woman in the military, and being able to have people that understand that is invaluable. You know, due to an injury that I incurred during my service, I currently have a neurostimulator implant in my neck. I'm 40 years old. To put that into perspective, I actually had the implant surgery done when I was 38 years old, 2 years ago, almost 3 years ago. I needed a neurosurgeon, and because, you know, the VA did not have, my VA medical center here in Huntington, West Virginia, did not have a neurosurgeon on staff. They made sure I got that care, and they made sure that I didn't have to worry about the cost. There is nowhere else other than the VA healthcare system where you can get specialized care like that. I mean, just think about that. A neurosurgery, the cost that for the regular everyday person, what that would mean. You know, I don't have to worry about that bill. I do not have to worry about if I have to go to the emergency room, how I'm going to pay for it. I don't have to worry about getting the mental health care that I receive, and not having to worry about how I'm going to pay for it. The VA healthcare system is the model for single payer healthcare. And if we can do it with the VA, then there is no reason why we can't replicate the process for everyone else in this country. Everyone should be able to have access to quality healthcare like I do. And so, when you're looking at this, there's no greater model than the VA healthcare system. It has been a blessing for me. It has been a blessing for other members of my family that have served. Every veteran I know, this is what we depend on. And I mean, the quality of care and understanding that my pain is real. That is, I have a lot of pain. I suffer from chronic pain, which is why I have the neurostimulator in my neck. It is to be able to manage my pain, to be able to have people that understand my pain is real. My health issues are real, especially, as a Black woman, where we do see in the private healthcare system, the systemic issues where a lot of the times our healthcare isn't taken care of the way that it needs. Our maternal healthcare is not what it needs. Pregnancy healthcare is not where our issues are not taken seriously. But in the VA, it is. In the VA, my issues, my symptoms, my pain, all of the things that I suffer through, my mental health is real. And so I thank you, Suzanne, for allowing me to come on and being able to just really express that this is the model that needs to be followed. And I honestly believe that we can get there, and that as long as we stay in this fight for that, we'll be able to see this come to fruition for everyone else as well. Suzanne?
I just want to thank you, Lakiesha. That was fabulous. I just want to ask you, because you're in West Virginia, and they're trying to shut down. I mean, they had part of the Mission Act had an asset and infrastructure review commission that fortunately groups like Common Defense and AFGE and I think VHPI really opposed and killed. And AFGE, the union, really led the charge among unions. And Common Defense was very involved in the Save Our VA campaign.
Yes.
PFP was very involved. But I just wonder, Lakiesha, if I might ask you, I mean, in West Virginia, what would happen to you if your VA closed? I mean, what access would you have to mental health care or primary care or specialty care in the so-called community? And I want to mention that, just as they've created this pernicious language for, pro-choice and pro-life and all this crap, pardon my French, they've created this language in the VA where, it's the Veterans Community Care Program, and vets are spent to the community providers. It should be called the Veterans Corporate Care Program.
Yes.
Veterans Corporate Profit Program. But I wonder, Lakiesha, in West Virginia, I mean, what would your access be like to private sector providers if you didn't have the VA?
Well, I mean, I can answer that. There wouldn't be. How about that? There's nothing. Before I was connected with the VA, when I got out, I was having, there was nothing. There's nothing there. I would not have healthcare, especially on the mental health side. My goodness. Trying to go through the mental health system here and trying to find quality care in the state of West Virginia, it is non-existent. It doesn't exist. So without the VA, many veterans like myself would not have healthcare access.
Yeah.
And that is, that was one of the many things that during, that situation where they were trying to close our VAs, it's like, do you not understand that this is our lives, this is our, our health on the line here, and we're not to be able to have access to that care, and trying to get through the bureaucracies of trying to find healthcare, or even trying to go through our West Virginia DHHR to be able to sign up for Medicaid. Oh my goodness. Don't make too much money. you're not able to be able to have access to that care. So it just would have been absolutely detrimental for myself and any other veteran in here. And I just want to also point out real quick that, with the VA healthcare system, if you live far away from from a clinic, from a veterans clinic or a medical center, how many hospitals or doctor's offices do you know will pay you a travel stipend to help you offset the cost to be able to get to where you need to go? VA does that. VA does that to help offset the cost to make sure that their patients are able to get to their appointments and make it to their appointments. How many other healthcare, private healthcare sector areas have designated, transportation for your patients that cannot drive or do not have access to a vehicle? Guess what? The VA system does. VAV helps get veterans to their appointments. So, it's all encompassing here. It takes care of not only our health, but our needs.
Yeah, thank you so much.
Our needs.
I just remember when I was visiting Fort Miley once, and I parked my car for free in the parking lot as opposed to paying, $30 or whatever I would have to pay at UCSF. And it was pouring with rain. And there was a guy driving a van, like a golf carts and he came to pick me up at the parking lot so I wouldn't have to walk across the street, God forbid, and get wet. And I'm like, oh my God. Anyway, Bruce Carruthers is a Vietnam veteran. He will introduce himself and he will end our presentation. Thank you, Lakiesha and Jim and Bruce, you're on.
Thanks, Suzanne, and thanks for inviting me and allowing me to talk. And I'll talk a little bit first briefly about my career. I worked for the VA for 30 years in 10 different locations, including a stint in central office, but I worked in psychiatric hospitals, in hospitals that were highly affiliated, in Denver, Colorado, and Birmingham, Alabama, and also in essentially small community-based hospitals, for example, in Erie, Pennsylvania. So I worked all over the country and I got a good idea, a good feel for what the VA was like in different settings. So not just being a veteran and receiving treatment at the VA, I also worked first in human resources, then in hospital management. But I would like to just give an example of my recent experience, which I think sort of mirrors what Lakiesha said here. I woke up on a Wednesday morning or Wednesday night at 11:30 with incredible pain. By 2:30, I told my wife, I have to go to the ER. This is just not getting better. It ended up I had gallstones. I waited 4 hours in the local emergency room. And when they discharged me, they set me up with an appointment with a local surgeon on Tuesday. Monday morning, I called the VA. Monday afternoon, the VA surgeon called me. Tuesday, I met with him and had the pre-op work done. Thursday morning, I was on the operating table. 2 weeks later, I was back to pretty regular activities. In 4 weeks, I was cleared to completely return to full activities. And that's been my experience with the VA. That's the kind of care you get. You don't have to wait for it so much, and they have your record and they take care of you right away. I also want to mention, and I think Suzanne might have talked about this a little bit, but the VA healthcare system does more than treat veterans. It has one of the largest research programs in the country, particularly at highly affiliated medical centers like the one in Birmingham, the one in Lexington, and the one in Denver where I worked. So many of the physicians have joint appointments. They work both at the VA and at the medical school hospital, and they conduct research that is funded both by the medical school, by grants, and by the VA. And a lot of that research benefits veterans directly, but also benefits the general public. It's not just research that's limited to veterans. Research they do on PTSD, for example. There are many people from other environments they've been in that experience PTSD. Research on prosthetics, which the VA is a leader in, benefits a lot of people that have disabilities, mobility disabilities. The VA also does a lot of education. Over a majority of doctors receive at least some of their training in the VA facility, and the VA has agreements for registered nurses, physical therapists, occupational therapists, physician's assistants, etc. Thousands and thousands of people are trained every year in VA facilities. If the VA disappeared, it would have a devastating impact on training healthcare professionals. We talked a little bit about this Veterans Community Care Program and referring veterans out to that when you go to see them. One of the real concerns we have this in the Save Our VA program is whether there's a level playing field or not. Now, the people who are proponents say, well, veterans should be given a choice. Do they want to see a VA doctor, or do they want to see somebody in the community? It's no choice if the VA is not fully staffed. If, for example, I want a hearing appointment at the VA and they say, well, you've got to wait 8 months because we don't have an audiologist on staff, but we can refer you in a month to see somebody in the community, that's not a choice. My choice would likely be, I want to be treated by the VA. I don't want to go to the local community. I like the VA. I like VA healthcare. So part of this understaffing is an intentional effort to make it look like the VA cannot provide the kind of services it does. The last report that I saw that the VA produced showed some over 60,000 vacancies in the VA. And in the top, I think 4 out of 5 were clinical vacancies. Nurses, primary care physicians. You can't provide the same level of service that you can in the community if you're not staffed. And then on this level playing field, the VA goes through an extensive credentialing for all its physicians. I mean, I worked in human resources and I know by the time we hired a physician or any healthcare practitioner, we had done a thorough review of their records. That doesn't happen in the private sector. People are referred to these physicians and all that's really checked is, do they have a license and have they been reported for any misdeeds or any malpractice? The VA is constantly reviewed. The Inspector General, VA Inspector General produces almost weekly reports on reviewing programs in the VA and points out where there are difficulties and makes recommendations for improvement. That doesn't happen in the private sector. And I'll give you an example here. Recently, and one of our attendees is from Asheville and probably can confirm this. I live in Waynesville, North Carolina, and the regional hospital here was Mission Hospital, and it was sold to Healthcare Corporation of America. After HCA took that over, some 60 physicians left because they were under pressure to see patients on a constant basis. You know, you have to keep turning patients over to turn profit over. Registered nurses actually organized and went on strike and organized a union at the Mission Hospital. And organizing a union is not an easy thing to do in North Carolina. It's a right to work state. But what happens with the VA is if something happens at one VA hospital, the press picks it up and people tend to blame the whole VA for that. It's the VA system is bad, and the press is just very happy to highlight VA errors and to pick on VA errors. They will be on the first page. If the VA has a breakthrough in research, it's likely to be in someplace inside the newspaper. Well, when something happens at an HCA hospital, Hospital Corporation of America, they don't change the name. They don't say HCA Mission in Asheville, North Carolina. They keep the name Mission, and people generally only associate it with that particular hospital. And the press doesn't pick it up. The press doesn't say, here's something that happened in an HCA hospital. The whole system should be condemned for it. So the VA isn't on a level playing field in a lot of ways. The last thing I wanted to mention, so I won't take up too much more time, is we talked about the integrated approach that the VA has. The VA was the first healthcare system to have an electronic medical record. And one benefit from this was mentioned before. If I'm on vacation, I have a son one who lives in California, one who lives in Texas, and one who lives in Denver. If something happens to me and I go to one of those VA hospitals there, my medical records are immediately available to any provider in that hospital. So It's not a matter of sending for them. It's not a matter of faxing for them. You know, if you've been involved in the private healthcare sector, which I have, getting your records transferred from one place to another is a very difficult situation. It's a fragmented system. It's up to you to try to get your records transferred. And you'll go in, you'll see somebody and they'll say, we need an AKG. And you'll say, I just had one. Well, we don't have that. We need to do it anyway. If you're in the VA, they can immediately look at your EKG, any other test you've had, an MRI that you've had. And the last point I want to make is to endorse what Suzanne said about it not being a profit organization. I talked to a lot of physicians when I worked in the VA about why they wanted to work for the VA. And the number one reason they said is they can practice medicine the way medicine should be practiced. They don't have to worry about if there's capacity, if they have an MRI, there's pressure on them to run as many tests as possible to make that MRI possible. There's pressure on them to see a patient in every 15 minutes. They said we can practice medicine the way it was meant to, and we can actually take care of our patients and get to know our patients. And you know, you have a continuing record in the VA, and the VA now has a 1 million veteran study going on, which will be the largest continuous study of patients in the United States, maybe in the Western world, but at least in the United States. Those are all benefits that come from the VA that could be available to everybody if the VA was a model for healthcare in the US. I won't take any more time, and I thank you for listening to me.
Thank you so much, Bruce. And I just wanted to add to, before we go into questions, that research is one of the VA's four missions, the Veterans Health Administration's 4 missions. And for example, as Bruce talked, the Million Veterans Program has the biggest genomic database in the world. The VA Brain Bank has the largest collection of brain tissue in the entire world. And that research benefits everyone. They're doing research on PTSD, Alzheimer's, and it was a VA researcher, Anne McGee, and it's never mentioned that she was a VA researcher, interestingly, that is using this brain bank tissue, establish the connection between chronic traumatic encephalopathy and concussions in football players. So, you know, the VA, I think the really important thing that we have to mention to people when we educate about the VA, because a lot of people think, oh, that's great, they're doing research, but it just benefits veterans. Well, I got the first shingles vaccine, thank you, VA. You know, the barcoding, thank you, VA. Nicotine patch, thank you, VA. Research on COVID, thank you, VA. One could go on and on. And I also wanted to mention the VA's 4th mission, which is to serve as the backup for the American healthcare system or non-system in times of war, terrorism, or national emergencies. So for example, in New York and New Jersey, Louisiana, and other hotspots during COVID, VA sent staff to private sector hospitals. VA opened its own ICUs to non-VA patients. And VA is, I think, one of the only healthcare systems that takes equity seriously. The American Journal of Public Health in 2014 had an entire issue devoted to VA's equity efforts. And during the COVID, there was no higher rate of deaths of people of color from COVID in the VA because they had access to care. And actually one study showed that in the VA, African-American patients with certain kinds of heart conditions, which you all would understand and I don't, you know, actually had better outcomes than white people at the VA because they had access to care and they had some natural advantage. I don't know, again, so, I mean, the VA obviously isn't perfect. It's a human system. It has problems, but also it's the only accountable healthcare system in the country. And the reason why we know about every little blip or problem is because it's accountable to Congress, the Office of Inspector General, the Government Accountability Office, et cetera. So there's many more things we could all mention, and I know you want to open it up to questions, so I'll shut up.
Suzanne, there was a question about what percentage of care is being sent out to the community. There's the financial impact of what's going out to the community is measured. Suzanne, you have that number, don't you?
Yes. So essentially with this Veterans Community Care program, and I prefer to always say private sector, but the amount of care that's going out to the private sector is it's now almost up to 60% of patient visits. It's now up to, in 2023, the amount of money going to the Veterans Community Care Program, which is this really corporate care program, was eating up 35% of the VA budget. In 2024, it's almost up, it's gone up about 9% a year. And they're actually in the president's 2024, FY 2024 budget, they have a decreasing amount for community care and an increasing amount for this medical community. I mean, there's two accounts in the VA. In 2023, it was about 128 billion. And 35% was going to private sector care. In the FY 2024, there's an increase of, I'm sorry, I should have it at my fingertips, but I don't. It's by 2025, they think that it will be eating up almost half of the budget for clinical care in the VA. I mean, that is a disaster. And I want to just say that this Veterans Community Care Program, the Trump administration, this was a Trump initiative, right, and the Mission Act, and the wait times, eligibility for community care for private sector care is dependent on drive times and wait times. If you have to wait more than 20 days for a primary care appointment or mental health appointment and drive more than 30 minutes, you can go to the private sector. And for specialty care, if you have to drive, wait more than 28 days and drive more than 60 minutes, you can go to the private sector. But the private sector doesn't have to see you in those wait times. So you can be a veteran and call up and say, I want a dermatology appointment at the VA, and they say, I can see you in 40 days. And then they'll send you to the private sector where the wait is 8 months. I mean, Jim Martin actually prescribed, did some care intervention for a friend of mine who's an older gentleman with prostate problems who had benign prostatic how do you say it? Whatever it is, BPH. And he couldn't get a urology appointment for 5 months in San Francisco because they want to save all their urology appointments for patients who are getting surgery. And I had to call Jim, and Jim, the ER doc at the VA, told my friend what to do. I mean, it was like a joke. And I'm not, an ordinary person. I know a lot of people I can call like Jim. Are we supposed to, who's handling the questions? Anna, are you, or are we supposed to be dealing with the questions?
I have my list.
Oh, okay, fine.
And I'm ready to start. There's a lot of questions.
I'm sorry, I was confused. Judy, go.
Kind of along the lines of what Suzanne was just talking about, the first question from Carolyn, who lives in Alaska, was how does the VA manage care in areas where there aren't any VAs and no VA staff physicians or other staff available, like in Alaska?
Right. Well, the VA, and this is a problem in rural areas, and particularly remote rural areas, where there's a difficulty recruiting people to work there, and also there isn't sufficient patient population to support maintaining your skills and so forth in those areas. So the VA, before the Mission Act, would send you, so let's say you were a veteran in Alaska and you needed a cabbage, right? And they couldn't do it there. They would send you, I'm not sure where, they would send you to a place where you could get it. And then they would pay your way, they would pay your hotel, and they would also pay for your family to go there. I had a friend who needed a cabbage who lived in Alaska and couldn't get it there. And he had to come, he got in Boston, had to come and stay at my house because he couldn't afford to stay at a hotel. The VA also has a huge telehealth capacity, which they utilize. And telehealth, as you know, in remote areas is a huge problem because we don't have adequate broadband access in those areas. That's like a, you know, the VA can't solve that problem. But actually, for purposes of telehealth, if a veteran doesn't have an iPad or a laptop or a phone, they will give them these devices so that they can utilize telehealth. But we need clearly more community-based outpatient clinics in some places. But, you know, we have a terrible problem, and I'm going to put in the chat. There's a wonderful information source called the, for those of you who don't know about it, the Rural Health Information Hub. And they have charts of healthcare professional shortage areas for primary care, mental health, and dental health. And America is essentially a desert for, you know, a desert for mental health, primary care, and dental care. It's unbelievable, these maps. I'll put it in a minute. 50% of American counties have no psychiatrist, social worker, or psychologist. And, you know, we are not producing enough primary care doctors. I mean, you all know about this. And we are not producing enough mental health providers. 45% of American psychiatrists won't accept insurance of any kind, even though we as taxpayers pay for their graduate, you know, their training, and they are allowed to say that they won't take Medicare or Medicaid or private insurance. So, you know, the VA is dependent on the supply of physicians, nurses, psychologists, et cetera, in the mental, in the, you know, they don't have their own schools. And I mean, one of the things that would help the VA is the Uniformed Services University, which produces doctors, nurses, and dentists, and I'm not sure on any other groups for the public health service, and the military is not allowed to produce providers for the VA, and that would help if they were, if Congress would mandate that they produce providers for the VA, but that wouldn't solve the broader problem in the American healthcare system of these shortages.
Sure. So there were a number of questions about wondering not so much budget percentages, but what are the numbers of outsourced staff and physicians rather than the percentage of the budget that's spent on private services?
Well, the physicians aren't outsourced, Judy. It's the care that's outsourced. So there's 1.2 million providers in the Veterans Community Care Program. And I mean, staff aren't out, you know, I mean, one of the cockamamie ideas that the Trump era consultants and that was for this Asset and Infrastructure Review Commission that was mandated to look at what VA facilities to shutter, repurpose, or add. One of their crazy ideas was embedding VA staff like nurses and doctors in private sector hospitals to take care of veterans. Now, there's healthcare providers and clinicians on this call. Imagine how that would work. Anna, Judy, you know, Jim, I mean, if you were, you know, embedded at UCSF or Sutter to take care of veterans, I mean, the whole thing is just ludicrous.
Mm-hmm.
But right now, the outsourcing is the privatization. It takes two forms: sending patients to private sector providers, right, who charge more and deliver lower quality care, and we can document that. And then I would argue that there's an internal privatization that's going on where they're increasing and the kind of productivity pressures that doctors and nurses and others experience in the private sector, and decreasing the amount of time they have to take care of veterans. So they're trying to erase the VA advantage over the private sector and sort of turn, you know, the system into a mirror image of the privatization of the private sector. Somebody, a mental health person, just described it to me the other day as the Kaiserization of the VA.
So, you know, people had questions about comparisons of the trauma-based or trauma-informed training that VA staff are getting. And is there any data that has shown an impact on reducing the suicide rate amongst veterans as a result of trauma-informed care?
Yes. The suicide rate of veterans has decreased when you look at vets who get their care at the VA. And so, you know, the statistics on veterans, the statistic of, you know, 2020 or 22 or whatever it is that particular year, that is all veterans. And the majority of those people who die by suicide who are veterans are not cared for in the VA. For example, when the figure was 20 per year a couple of years ago, 16, I believe it was either 14 or 16, please forgive me for not having at my fingertips, of those patients were not seen at the VA. Now, one of the problems we have getting folks into the VA, and Jim, maybe you could talk about this, is, you know, there aren't enough, they've been closing psych beds. You know, they don't give people enough money to deliver the services, and then they complain that the services aren't delivered. Jim, do you want to talk a little bit, or Bruce, or, you know, about sort of trauma-informed care, or, you know, you as an ER doc, I mean, you're trained in suicide prevention, right? I mean, you get training in all these things.
Yeah, well, mental health is a large percentage of my practice. We have a psychiatry residency on site. We have young psychiatric physicians coming down to do the evaluations and get them admitted. And okay, so what impacts me mostly is we're down a few cardiologists, and that's a tough specialty to be down, and having to refer them out, that's bothersome. I don't know why. We're supposed to go, okay, so nurses now have locality pay surveys that impact their salaries. Physician assistants have locality pay surveys that adjust their salaries. Now, this is probably something that Congress is going to take a look at for physicians, because you have to be at market pay. If you're not, you're going to have trouble recruiting. And then the recruiting process itself is somewhat arduous and takes a long time, and we're trying to get that streamlined. So we could do better with our recruiting process, and we could do better with our market pay for the physicians. That would be a big difference. And then the PACT Act, which just came, which is the burn pits. And I am seeing young veterans with the effects of this devastating exposure, and it's real. And we need more comp and pen physicians to evaluate these younger veterans coming into the system. So we're short. That's really the problem, and we're not hiring, or we're hiring too slowly.
Yeah, I put in I mean, one of the things that the Trump administration did to cripple the VA very deliberately, and Trump really wanted to kill the VA with his pals in Mar-a-Lago, was they created this human resources modernization project. And I put articles about it in the chat. And again, this, if you go to the VHPI website and the AFG website next week after March 21st, you'll see our report on both websites. But one of the things that Trump did was cripple an already cumbersome human resources process by taking human resources staff out of local VAs. It's a disaster. And one of the problems that the VA has, and that Congress really needs to fix, is that no VA employee is allowed to make more than the president of the United States, which is like $400,000. So, you know, one of the reasons why Lakiesha had to go to a neurosurgeon, an outside neurosurgeon, is, you know, neurosurgeons, they can get $1 million a year. Interventional cardiologists, like, what is it, Jim? Like 800,000 they start at. I mean, you know, one could argue that why do these people have to make that kind of money? But how can you ask somebody to work at the VA for $600,000 less? I mean, that's, you know, and so actually what ends up happening is that then they hire neurosurgical practices. They contract with practices and they pay the money to the neurosurgeons, $1 million as contractors. Plus, you know, they have to run through the agency that, you know, sort of is like, you know, contracting is the middleman between them. So all of this can change and must change. But, you know, they don't want the VA to be able to compete with the private sector.
Sure.
That's the reality, because it has won the competition.
I have a question I think I'd like to direct to Lakiesha about what type of quality improvement processes exist within the VA, and if you could tell us about the opportunities that VA participants and patients have to provide feedback on the care that they get. Somebody did put an answer in the chat, but I thought this was important enough that maybe you'd like to comment on that.
Yes. So one of the great things about it is that they actually have a office within the VA, kind of like it's a social worker within the VA within the VA medical centers, within the clinics, to where if you are, you know, if you're finding that you're having issues, or, you know, that you maybe have been through a process and you could see where things can be better, they have a total open door policy. It is nothing for you to get done. I mean, I've used it myself. You know, it's nothing for you to get done with an appointment and just walk right over and knock on the door. And they're there, you know, waiting and willing to listen. You know, even within, you know, the offices of the doctors, you know, these doctors' offices within the VA, your primary care physicians, you know, if you see you have a quality of care issue, or you know, see these things, or there's something that needs to be addressed and you feel like they're not being addressed, thankfully enough, you know, the staff there and the people that they have working within the VA, they are there to listen and they take those seriously. So it's a wonderful process that they do have. Like I said, it's completely open door. I don't even have to make an appointment to go, you know, and say, oh, I need to, there's an issue, you know, or any given time, like I can pick up the phone and call someone. I can talk to someone within my doctor's office. I can talk to my nurses. I can I can call that office myself, and, you know, to be able to do that. And, you know, the feedback is positive. You know, thank you for bringing this to us so that we can create and make the experience better and, you know, address those issues.
And Lakiesha, you were so positive about women's health care in the VA. I'll address this question that came in the chat. If you have any knowledge about whether the VA, how it manages domestic violence and sexual abuse.
So trigger warning. You know, it's because unfortunately, it is a prevalent issue. It's a prevalent issue. Sorry, my son opened his door to his room. I don't know if y'all heard his movie playing in the background. I'm a mama.
No, you're
so.
fine. You're fine.
But yes, it, you know, it's an issue.
Mm-hmm.
Okay. There's not
trauma-informed care.
Trauma-informed care. It's an issue, and they know that in the military these things happen to our female service members.
And men too, I think.
And men too, and men too. You know, but they do know that these things happen. And, you know, it is a judgment-free, safe space that they create. To be able
Can I go back to a question about suicide prevention?
Sure.
Somebody asked what the VA does. I think Suzanne mentioned, but the rate of veteran suicide is much higher than in the general population. And the rate by which veterans take their own life through firearms is much higher, sometimes a matter of 20 or 25%. But the VA has really tried a lot of innovative approaches, and it's the approach that it is developing and taking now is called a sort of whole health approach. And generally speaking, the approach that's taken by most providers, or the VA took in the past, was a clinical approach. Somebody is diagnosed with potential suicidal ideation, and then they're treated. What the VA is trying to do now is to reach out to family and friends and to find out, is anything about this person that you're concerned about he or she thinking about harming themselves, and getting the whole community involved in treating the veteran, rather than just saying, okay, here's a clinical diagnosis, this person might be at risk for suicide, and then treating them. They're trying now to reach out to friends and family and identify in advance when there might be an issue. And as Suzanne mentioned, the VA has had some success in reducing veteran suicide. I mean, it's still a huge issue, and the VA recognizes that, but they have. And the second point I wanted to make about quality control, in any VA hospital, there are a number of review boards. Anytime when there's a surgery, there's a review after that. Anytime there's what's called a misadventure, there's a review after that, and there's a discussion and corrective action is taken. But in addition to that, and I don't think people realize the importance of this, the VA Inspector General does reports constantly on medical centers and VA networks, and reports those to the public. So you can go to the VA Inspector General's office and you can sign up to get these reports. And almost every week you'll get a report that will review the VA hospital in Lexington, Kentucky, and they'll say, we found issues in these 4 areas. This is what we proposed, and this is what the medical centers will do in response to that. I would challenge you to find any other healthcare system where you could find routine investigations, or you can call your congressman and say, look, I went to the VA and had a problem. And I know, especially from working in VA central office, if a member of Congress calls the hospital, you respond immediately. You investigate that and you get a response. And you can call your congressman now and say, hey, I went to a Hospital Corporation of America facility and things didn't go too well. And they'll say, well, I can't really do anything about that. That's a private institution. So the VA is incredibly transparent and studies itself constantly, and constantly tries to improve in a way that I don't think we see in the private sector. Few
No.
people appreciate that. And I think if they did, they would say what Suzanne said before, why don't I get that kind of care? Why isn't that available to me? If they had the experience I've had in working for the VA, I think most people would say, well, how come only veterans get this? Why isn't this available to all of us? And it should be a model for healthcare for everybody.
Yeah, and then just, to the point, one of the things, just even in the processes, right? When you go to see your primary care physician and you go to these appointments, even if you are going to see a specialty care doctor at the VA, they actually have a process when you sit down with the nurse getting ready for that appointment, to actually ask about these things, so that way they can identify them. Do you feel safe at home? Are you having these issues? Or do you have the resources that you need at home? Trying to identify the needs that the veterans have and how we can best address those issues. They do an outstanding job of identifying that straight up right there and there because of the process that they have. And it just doesn't, they're so comprehensive in their approach that they're able to just make, targeted, be able to just target the issues and being able to connect veterans with the services that they need so that we can continue to have a quality of life after service. And to me, wouldn't that sound great for everyone? To be able to have. So yes, so thank you.
I'm gonna keep you in the spotlight, Lakiesha, because I know this. You mentioned that you did have a service-connected injury, and the question that was posed is, what is the current requirement for service-connected illness in order to receive care at the VA?
So that is, you don't actually have to have a service-connected disability to be able to receive VA services. If you got out of the military and if you served, you have access to VA healthcare. As far as being being able to with a disability process, all that's done through the VA, right? For us to be able to, go through the process of applying for disability and having our conditions that we, have attained from our service, there's actually all the doctors that we see that do the reviews for us, like Bruce was saying, everything is right there. All of my military records, every time I went to a doctor, every time I saw a nurse, if I went in and got an aspirin, it is in my records that the VA can access. So when you're going through the process of getting your disability, the people that you're seeing in the VA healthcare system already know what your issues are. They can review your files to make those determinations, and then can make sure, and then come to the conclusion about whether or not your diagnosis is a service-connected disability. But all that's handled within the VA. Without the VA, we wouldn't even be able to cross that and make sure that veterans that come out with disabilities get the benefits that are deserved to them. So, I mean, you can't beat it with a stick.
So I just want to add something to that. Can you hear me? Because I just put on
Yes.
this headset. So essentially, actually, Lakiesha, it's true that there is now, it was 5 years and now it's 10 years of free care for people who have served in combat zones after 9/11. For other veterans, unfortunately, there are eligibility requirements that Congress has imposed on the VA because we refuse to pay the cost of military service and war. And so basically, if you are not a combat veteran, post 9/11 combat veteran, you have to either have a service, confirmed service-connected disability and or low income. So the VA actually cherry picks the sickest, poorest, and oldest patients. So, unlike other healthcare non-systems that, want the healthiest and wealthiest, the VA actually chooses the poorest, oldest, and sickest, and actually delivers better health outcomes at lower cost to them. And one of our demands at VHPI, and I know SOVA, is that all veterans should be allowed to get care and education from the VA, regardless of how long they served or what whether they have a proven service-connected disability, and also low in whatever their income. And also the other thing that determines whether you get VHA care or VA benefits. VHA healthcare is just one benefit of VA. VA also administers the GI Bill, which gives free education, home loans, your veteran status that allows you to get discounts at Home Depot, whatever, veteran hiring processes. Your discharge status is written in your discharge paper. There's a narrative of your discharge, and there is a type of discharge that the Department of Defense administers to get rid of its, quote, problem children, like problem children being women who report that they were raped by a superior officer, people who got drunk because they have a traumatic brain injury or PTSD, and they discharge them with what's called an other than honorable discharge that denies them care and benefits from the VA. All care and all benefits. It's called other than honorable bad paper discharge. 600,000 veterans now have that, and they predominantly discriminate against people of color, women, etc. And this is a travesty that should be addressed. And it's the DoD that does that. The one thing I want to point out is when you're looking at veteran suicide or many of these other problems, the VA gets blamed and is a really convenient whipping boy for the Department of Defense. These suicides that we are dealing with in veterans were not created by the VA. They were created by the DoD. And it's just, I'm sorry, I get apoplectic about it, but
Let me just sort of tag on two things there. We're talking about eligibility for care in addition to these priorities based on income. If you have any service connection, you can get treated for that at no cost. If you're 50% or above, then you're eligible for any treatment. So any veteran who has a service-connected disability, it's worth their while trying to appeal that to get to at least 50%, because then any care that you need is completely free to you, including prescriptions, hospitalization, anything. The second thing about the bad paper discharges that Suzanne talked about, and something that we have been working on, all the law says is that if you have other than a dishonorable discharge, you're eligible for care, for VA benefits, for healthcare benefits. The VA has constructed an extremely complex set of regulations to determine for those people who fall between dishonorable and honorable discharges, whether they're eligible or not. And so, for example, one of the standards is moral turpitude. And so what is moral turpitude? I actually testified on this, and the point I tried to make is what one person's moral turpitude is to another person is their pleasure. I mean, it's very confusing. And after World War II, less than 1% of enlisted soldiers were discharged with anything other than honorable discharge. By the time we get to post 9/11 veterans, it's 16%. And what happens is it's very convenient. So you get in trouble in the service and they say to you, well, look, you can have a court martial or we'll give you a general discharge. And they don't tell you what consequence you will face for that. In fact, at the thing I testified at, several military officers, former military officers, said if they'd known what this was going to do to the people they talked to, they would not advise them to take these administrative discharges. There's no due process involved in it. They can simply be given a discharge or out the door. They don't realize what the impact is. They go to apply for VA care and they're excluded because they don't have an honorable discharge. And there's no reason for that. The law doesn't require it. The Secretary of Veteran Affairs has the power to change this. He proposed changes in the regulation that were supposed to come out this past November and still hasn't done anything about it. We have been trying to pressure them. We in Save Our VA and healthcare in Veterans Public Healthcare Institute and other veterans groups been pressuring the VA to change that. And Senator Sanders introduced a bill called the Turnaway Bill, but so far nothing has happened to change the standard. The disadvantages, as Suzanne said, 600,000 veterans. I mean, people who should be eligible for care. The best analogy I've heard is if you're a coal miner and you get black lung disease and then you get arrested afterwards for possession of marijuana, you're not denied your black lung benefits. We have people in Veterans for Peace who have served several tours in Iraq and Afghanistan and were caught with marijuana towards the end of their enlistment, were given an administrative discharge or other than honorable discharge, and they're not eligible for the health care that they earned. It is a travesty. It is maybe affecting so many veterans. It's maybe one of the biggest travesties that both the Secretary of the VA and Congress is yet to address.
Wow. We're getting close to the end, and I haven't been able to get to all the questions. A lot of resources have been dropped in the chat, and I would encourage people to look at those. I think the other thing that has been dropped in the chat are the action items that we would like people to pursue. One of the questions was, what would be direct action that could be taken? And so those, Anna has dropped those items into the chat, so you can hopefully all pay attention to those. I mean, I think listening to all of these wonderful speakers who have different experiences within the VA, all contributing to such a robust picture of what we have. I'm not sure if this is more of a rhetorical question, but we all need to think about what would it take to have a VA system for everybody. It's really what we need. And, you know, I don't have the full answer, but you've really exposed the good about the VA and the pernicious side of things that unfortunately we've heard about, especially ending with these discharge papers. So, you know, I think I want to thank everybody for coming, and particularly to the 4 speakers who did such a beautiful job painting this picture for the VA.